Boa tarde a todos. Nós temos o prazer de ter hoje conosco, apresentando um seminário, o André Rogatko. André tem uma longa carreira já, principalmente na parte de bioestatística. Dentre outras coisas, André Rogatko é diretor fundador do Biostatistics and Bioinformatics Research Center, no Samuel Hoskin Comprehensive Cancer Institute. Também no Cedars Sinai Medical Center, em Los Angeles. E é fundador do Biostatistics Shared Resource at CSMC, em 2008. Bom, são várias coisas, eu vou dar uma enxugada aqui na biografia do André, porque é bem longa. Então, dentre suas várias contribuições na área, André publicou em torno de 133 artigos, 14 capítulos de livros, 9 aplicações computacionais em bioestatística e genética, e ele tem desenvolvido métodos Bayesian Adaptive para a melhoria do desenho e fornecido ferramentas mais analíticas, ferramentas analíticas mais eficientes em estudos clínicos de câncer nos últimos 20 anos. André, mais uma vez, obrigado. Sinta-se à vontade para começar.
Então, obrigado a vocês. A palestra de hoje vai ser diferente do que eu tenho trabalhado nesses 20 anos, que é de métodos adaptativos bayesianos. Então, tudo que eu vou falar hoje não é bayesiano. Então, para todos os meus colegas bayesianos, isso é uma dica para vocês pegarem tudo que não é bayesiano e trabalhar para transformar em bayesiano. E também a minha maneira de apresentar, o que eu assumo é que vocês são todos estatísticos e vocês sabem muito de estatística, mas o que vocês têm menos conhecimento é o problema que motivou a solução estatística. Então, eu vou falar mais da parte não estatística do que da parte estatística, de certa maneira. E vocês têm os 2 artigos que a gente publicou, um foi numa revista que é mais clínica, o primeiro, o segundo que é mais estatística, e tem muitas coisas abertas, e muitas mesmo. Então, se vocês tiverem interesse e vocês quiserem desenvolver pesquisa nessa área, vocês podem me contactar, o Vinícius e o Márcio, que daqui a pouco o nome deles vão aparecer aí, e vai ser o nosso prazer colaborar com vocês. Então, vamos agora mudar de língua. So, we'll be talking about the evaluation of treatment tolerability in cancer clinical trials. So, the reason why I'm talking about that is because there was a cancer moonshot research initiative that they invested $1.8 billion in 2016 to improve research in cancer. And their goals is to minimize cancer treatment side effects, and because of that, there was created a Tolerability Consortium. In this Tolerability Consortium, they had grant announcements. We submitted an application when we got. So Patricia Gans from University of California and myself, we submitted a grant advancing analysis and interpretation of adverse events and patient-reported outcomes in cancer clinical trials, and it was funded. And we are really privileged because we have a very high quality team that includes 2 Brazilians, Marcio Diniz and Vinicius, and several statisticians from our group, from UCLA, from Brigham's and Women's Hospital at Harvard. NRG is a place in University of Pittsburgh that they run clinical trials, and Lynn Henry that she is an MD, and she will be co-author or first author in one of the papers will be mentioned. So during 3 years, we have these 5 published and accepted articles. When I sent the abstract, I was going to talk only about these 2, but then meanwhile, we got another acceptance in this Journal of Clinical Oncology. That is a very high impact journal. I think it's more than 35. And I'll be talking a little bit about it as well. So the name that appeared several times is tolerability. So what is tolerability in terms of experience? So you see that cancer treatment, different from many other treatments, having side effects, so adverse events that are sometimes very severe, it's something that is common, or to say the other way, is not uncommon to have them. And they are associated with the intensity of the treatment. So the more intense is the dose that I get from an agent, it increases the probability of adverse events. At the same time, patients will continue to be willing to be treated because of the adverse events. If they are too bad, the adherence to the treatment is going to decrease. So see, tolerability has to do with adherence. And what happens in terms of inside of our bodies is really complicated. But let's go through this busy slide here to have an idea of what's going on. See, once you have a cancer and you're giving a treatment, so this drug is enter in you either by injection or by oral, and it's absorbed. See, once it's absorbed, it starts to distribute, and part is eliminated, for example, by your kidneys, and part is metabolized by your own body, because it's most of those drugs are bad for your body, because they need to be bad for the cancer, so they are metabolized too. And everything that has those arrows here is influenced by your genome. So each of us is going to eliminate and metabolize our treatment in a different way. And that's why it's complicated to find the best doses and the best treatments for everybody. So what is left from not being eliminated and not being metabolized, you're going to be in all your body, including where the tumor is. So if we can have a lot of the drugs around your tumor, see, it's going to be an efficacious treatment. That's a clinical response. And everything else that goes to other tissues is going to produce some toxicity. This is also influenced by your environment. For example, if you drink heavily, your liver is not going to be as good to metabolize the treatment, and this may change how things go. But going back to toxicity, see, there are 2 ways of measuring toxicity. One is the clinician is going to assess you, is going to take a look on what it's called adverse events, and you're going to talk a lot about that. And the other one, patients themselves can report how they feel at several things, and those are called patient-reported outcomes. So, and that's why it's in red here, because that information can go back and change how the drug is administered, how the treatment is given to the patient. So an adverse event or a toxicity is everything that is bad that happens to you. And it may be related to the treatment that you're having, or maybe not. Sometimes you don't know. And this is something that is very important to see how you can treat the patient in the best possible way. To give you an idea of the complexity of adverse events, see, there are 790 so far described in something that is called the Common Terminology Criteria for Adverse Events. See, you're going to see this acronym several times, CTCAE. And this is in a version 5, and all those toxicities are grouped in organ classes. And we are going to see an example of that. But what is important, they are described in a way that they are graded according to 1, 2, 3, 4, or 5. 1 is very mild, 2 moderate, 3 severe, 4 life-threatening, and 5 is death. So, and 3, 4, and 5 are called, as a group, dose-limiting toxicities. So see, if you, the usual way of thinking is that you have grade 1 or 2 is not that bad, but 3, 4, and 5, especially 5, it's really not good. You can see an example on 3 types of adverse events in this catalog of more than 700. So it's neuropathy in terms of motor, neuropathy in the way you sense, and tremor. So, and see, those are the grades. If you have that neuropathy, motor, asymptomatic, so without symptoms, you only have some weakness that the physician can detect, this is grade 1. If it starts to interfere with your activities of daily living, then it's grade 2. If it's so bad that you need to have a cane, or a walker to walk, it's grade 3. And if it's totally disabling, you are paralyzed, is 4, and if it produces death, it's 5. And you can see that, for example, for tremor, you don't have that, but you have this disabling, and all those grades are kind of analogous. So you can, what you'll be using in the when we do to work statistically with them, if a person has a grade 2 in neuropathy motor or a grade 2 in tremor, we are going to think of those 2 adverse events as being equivalent because they have the same grade. And this is an idea of what happens in terms of tolerability. So think of tolerability as the patient can tolerate the treatment without stopping. So if you have low toxicity, see, it's high tolerability. If you have high toxicity, is low tolerability. However, if you have grade 2 or 1 toxicities that are very low, but they persist for a long time, see, you have a tolerability problem as well. Having vomiting like slightly for 5 years every day, it's something that you cannot tolerate. So see, there are 2 concepts associated with tolerability. One is how toxic it is and how long it persists. And now we are going to talk about this paper. So we already have a good idea of what is tolerability. And we are going to talk about this toxicity index as well. And to do that, we are going to use data from a clinical trial that is neoadjuvant chemotherapy, means that the chemotherapy was given to the patient before surgery. Because so before surgery of rectal cancer, they are going to have the chemotherapy, and after that they are going to have also, and before surgery they have also radiation. So they have radiation and chemotherapy to downstage the tumor and decrease the risk of recurrence and improve survival. And this trial was interesting because it started with only 2 treatments. See, 5-FU is the standard treatment, and capecitabine, that I'm going to call CAPE only. It was a new treatment that they were being compared to 5-FU. However, during the trial, a new agent that was given with both of those was added to this trial. So it became an incomplete factorial design. And this is what happened. So you had 1,600 patients, and before the amendment, you have those 2 agents, and you see they were given 7 days a week. So the intensity is every day. But because on the oxaliplatin was introduced, they needed to decrease the intensity of the other ones. So in a sense, now you have 4 different treatments here, CAPE with oxaliplatin, or a 5-FU and 5-FU with oxaliplatin, but you have these other 2 that are in different intensities. So you have 6 different treatments. See, so this is the first plot that we've done that nobody has ever done through all these decades of treating cancer patients. So in the x-axis, you have the number of adverse events experienced by patients, and on the y-axis, you have the relative proportion of the grades observed. So green is, so these are a series of bar plots. Green is no toxicity at all, grade 0. 1 is slight, mild toxicity. 2 is more toxicity, and 5 is death. And you can see you have now those 6 different treatments that one treatment like this one here, 5-FU in the forearm that had lower intensity of a 5-FU, the mode of the distribution is no toxicity. So that's good. So there was no toxicity. On the other hand, this one, CAPE plus OXA, it had patients that are having 22 different types of adverse events. And see, that's pretty serious. In this little table inside, see green, like the traffic lights is good, red is bad. You can see that many patients, more than 20%, are getting serious toxicity here. Here is more around 18%, so it's less. Here is around 18% as well. And this gives you an idea of how, see, what is the toxicity experience that patients have in this trial. So now let's go with more detail. You have the first 19 patients of this trial. So in that column, you have the treatment. Then if you have it was male or female, and then you have a series of adverse events that they had. So see, this patient 2 had abdominal pain, grade 2, anemia, grade 2, anorexia, grade 3, diarrhea, grade 3, fatigue, grade 3, and so forth. And as I mentioned before, because the grades we can assume as they are equivalent in terms of toxic experience, we can reduce our data to something simpler like that. And you can see also that this patient 2, this female, she had much more events of toxicity than other patients. And to make things easier, so let's sort that experience of these patients, putting on the left side the highest toxicities. Then you have something like that. See? And I'm putting 4 as the red, 3 blue to make it easier to see. So a new concept for you, but any oncologists know, is the concept of max grade. See, what oncologists they do, they look at all toxicity experience of a patient and take the maximum. So that's a good thing, because you see, it's a way that you're summarizing your data. But at the same time, if this patient has 4 grade 4, 2 toxicities grade 4, and this has only 1, they have the same max grade. So in a sense, you are losing some information. And let's do something else. For example, if I have a patient that has this one here with 2 grade 4 toxicities, I can say that this patient experienced more toxicity than that one with only 1 grade 4. So for any pair of patients, for example, if I compare this patient 2 with this patient 14, see, this patient had 2 grade 3 toxicities that are still less than 1/4. So I can always find a system of ordering those patients. So there is an inherent order on that system. So I can do something like that. I can order the patients by what they experience. Every clinician will agree that this patient here is worse than that one, that is worse than this one, and so forth. And again, you can see the limitation of the max grade, because for the first 3 patients, they all have max grade equal 4, and these ones that are all equal 3, but they are all different. Each one is experiencing toxicity in a different way. So that realization is what gave us the idea in 2004 to create an index that would measure the toxicity and take into account all the toxicity experienced by the patient. And we showed that we could show, but like just empirically, without any statistical rigorous proof, that it seemed that this method was much better in catching the differences between treatments. So how is this toxicity index defined? If you sort the grades that a patient has like that, and then you do a weighted average of them in this fashion, so this is how this thing is defined. And it was the inspiration of that was hash tables that are used in computing. So let's give you an example. For example, if a patient has 2 grade 3 toxicities, adverse events, the TI, the toxicity index, is going to be 3.75. If one subject has 1 grade 3 and 10 grade 2s, and you apply that formula, you're going to have a number that what is important is that if you have 10 grade 2 toxicities, this is still less than having another one. So see, this toxicity index for that patient is slightly less than that. So the TI is keeping the ordering of your patients. And as a property, see, for this TI, because the integer part is the maximum toxicity grade, see, this index was created to have that property. So therefore, if the score is 3 or more, is DOT. Sorry, here should be an equal. I need to correct. All toxicities are taken into account. Lower grades contribute little, and many toxicities of the same grade are less than a single toxicity on the higher grade. And for this particular CTC-AE that I mentioned to you, the toxicity index varies from it's 0 or more. It's between 0 and 5.833. And so why is that? Because see, if you go through the arithmetic of that index, you can show that the soup for everybody having 1 is 2. This is the soup for that is 3. The soup for that is 5. But see, remember, 5 is that. So far we can only die once. Because we can only die once, if you develop that series here, you're going to get 5.83 as your maximum. So if we add to that list the toxicity index, see, that's the toxicity index associated with all patients. And what you can see is that you have they are decreasing monotonically here. It's the only time that 2 toxicity indexes are the same is because the patients have exactly the same grades. Okay? Another further way we can compact the data is to write it as a vector representation, where in one column you write the frequency of grade 5s, grade 4s, 3, 2, etc. So see, this is a compact form. Okay, so now let's take that plot that we've seen before and apply our toxicity index to all the classes of patients that had different toxicities. Because the question is, if a patient has 10 toxicities, is that patient have on average more toxic experience than a patient that has only 2? See, because if it doesn't, what's the point of having a system that takes into account all toxicities? And you can see by the shapes of these distributions here that yes, indeed. See, as the number of toxicities increase, the intensity, the toxicity index increases as well. So that means that we have a measure that has something that maybe it's an interesting measure to have. However, the toxicity index has a little problem. it's between 0 and 5.83, but it's not a continuous measure. It's a wholly measure. See, you have values that are there and values that are not there. It is not normally distributed. It doesn't have any good distribution to describe it. So we need to have a way to represent its distribution. And we can take, for example, let's suppose this is not a toxicity index, are just control and treated populations, where you have a bivariate distribution for the controls very clearly, and less clear, but you still have for the treated. Okay, if you try to use a bar plot, that doesn't work. See, bar plots are horrible for continuous measurements, and here it's bad also. If you use a box plot, that's it. It's still okay, but you are not capturing the fact that you have a bimodal distribution here. See, this would be a better choice. And that type of diagram is called a Violin plot that many of you may know. If you don't, how you generate those? Well, you start with your histogram, and then you center the bars, you rotate them, you use the shape of that in the external part, and in the middle you put your box plot. So this is how you represent it. And this was proposed by Hinson and Nelson in 1998. So it's not that new. Okay, so let's go back to our treatments. And I mentioned to you that clinicians, oncologists, everybody always uses the max grade. So how about if we do a Violin plot of the max grade for our 6 treatments here? See, well, you don't need to have a great vision, but see, the medians here are exactly all the same. So that makes you believe that all those treatments are equivalent. So what does it happen if you look at the toxicity index? Well, the toxicity index, they are not the same. What we see, does it make sense? So what we know is the 5FU 4 arm is less intense than the 2 arm. So you can see that. You know the same thing for CAPE. 2 arm is more intense than 4 arm. And when you add oxaliplatin, what we saw in the first graph, if you may remember, you have worse toxicity. So we can see that reflected. And if you compare side to side the max grade and the toxicity index, you can see how different the same data, one was filtered through the max grade function and the other through the toxicity index function. They produce different summaries of what you're seeing. So how about if you look at different variables? See here, forget about everything, just compare males and females. And when you look here, it seems that females experience more toxicity than male. And this has never been described before. But we need now to do some inferences. And we are lucky that other statisticians developed probabilistic index models. See, the probabilistic index is the probability of superiority. So if you take an outcome, randomly selected subject, the probability that this other outcome, another subject has a higher probability condition on the covariates, it's called the probabilistic index. So see, this is an example. If I have groups A and B, they are exactly the same, the probabilistic index is going to be 0.5. If A is less than B, it's going to be 0.98. So you have, see, you're always measuring what's the probability that A is less than B, and you have a number you can associate with that. So this is an interesting framework because you can adjust for covariates, and it's a non-parametric test. So when you are feeding it to models, you don't need to worry about going to residues and see if your modeling is okay. So it's you are losing some power, but still it works. So that's a busy table. and you can look into detail of that in the papers. But we are going to focus in only one specific line here. If you do correct for everything, for toxicities, and you can see here, see how many of those treatments are worse than others in terms of toxicity. But if you look at males and females, there is a very significant difference. And so when we wrote that paper, we mentioned that in the discussion that we saw that. See, there was a sex between the experience. Women had significantly higher toxicity across treatments than men. And if we know that, we can use that to adjust treatment to increase tolerance and improve adherence. So what was interesting that a couple of months later, they did a meta-analysis using 34,000 patients using the max grade, and they identified the same thing, that their females were experiencing more toxicity for this type of treatment. So, and they did that with a sample that was 22 times larger than ours. Okay, so another player in this toxicity summaries is the average toxicity. See, we statisticians love averages. So is average a good thing to use to average grades? And so those guys propose that. And if we look at, for example, those patients here, so this one had only one grade 4, this one had grade 4 and 2 grade 1s. When you look at the TI, it's a little bit bigger for that patient. So as we know, the max grade keeps the same, but the average toxicity from 4 goes to 2. So see, it doesn't look promising, but we will see later how good or bad it is. If you compare the average in red, max grade in green, and toxicity index in blue, and those are several comparisons among the arms, you can see that most often the mean goes touches the 0.5. That means that it doesn't detect a difference. That just gives a suggestion that maybe TI is more powerful, but one way we can try that better is to take our samples and then vary the sample size and repeat that. So you keep resampling from your full sample, and by increasing your sample size, do your probabilistic index model and calculate if it was different or not. And then you can have a plot that has, for those 4 treatments, you could use for all of them, the power of each of those approaches. So again, the TI is blue, max grade is green, and mean is red. And for all the plots, you can see that you have the same order, TI being more efficient than the other 2, and the mean being the worst. So we clearly could conclude that for a given size, the TI achieved greater precision. And that was the conclusion of our paper, that TI worked well, and we presented some methods. But because of our time, let's go to the more statistical paper. See, because here we had some ideas, but then we could work better in terms of how well one could generalize those findings and what can be said about the TI, about the max grade, and about the mean. And this was published in Statistics in Medicine. One of the things we showed is that we had a closed form representation that is given in here that you can go and check for yourself. But what is from that formula, if K is equal 5, 5 is the number of categories that you are using. For us, see, 5 is because we have up to grade 5. You can write the TI function in an easier terms of computation. So instead of having products and sorting numbers, you can just plug your totals of grade 1, grade 2, grade 3, 4, and 5, and you get your TI. But there is something also important. See, if you look at that table, so you have patients 1 to 37, the way those patients are placed in this list, you can see that, for example, let's take patient 7. Patient 7 has more toxicity than patient 6, who has more toxicity than 1, than 5, than 4, etc. So if you go through all this table, we can show that all those patients on the right side have more toxicity than on the left side. Okay? And if we plot for those sequence of patients, the TI associated with them in blue, the max grade associated with them in green, and the average, you can see very clearly that the TI is the only one that is monotonically increasing. The max grade is a step function. So see, for patients that have different toxicities, is assigning the same, and the mean is much crazier. See, it's not a good concept to use to study toxicity. And what this could be formalized now is we can define more precisely what is a total order. And you can show that the set that we just showed before of grades and patients, it's a total order. And it's transitive. And we can show, in addition, that for any pair of patients that one has in this total order is more than another, the TI is going to follow. So that is that the TI is, the T order is a total order and provides a ranking for all elements of that grade. And it preserves the T rank, the TI. And the TI is injective, a one-to-one on the integer set. And this is not true for the other two measurements. So I'm not going to go into detail because of time on the test we propose. That is a very elementary test. We give an approximation to a Poisson distribution. And see, this is the, as you can see, the topology of those plots are not different from the ones you've seen before. But if you compare the sample size required with the test that I showed before, that was by sampling, it was a non-parametric test with the new one, you have really a very large improvement in terms of power. So to achieve 80% of power, see, this new test is 38% less in terms of patients required to compare and so forth. And again, is this a surprise? No, because we are having now a parametric test, and we know by the fact that TI uses more information that is better than the max grade, that is better than the mean. So that's a quick summary for what we discussed in the theoretical paper. See, we presented a closed formula, we defined what is a total ordering, we showed that there was the TI preserves the ranking, and we applied the test and showed that it's, in terms of power, is better. We didn't discuss the details of how you use a Poisson limit model to obtain this test. And you are please welcome to go to the paper and see it for themselves. Let's see, but what is important here? See, what the TI did is that, suppose that this is a rank 4 and this is a rank 5. Sorry, grade 4 and grade 5. The max grade was a step function. The TI was something like that. So that's why you improve the power. But again, you could have a function that goes like that, as long as it's monotonically increasing, or a linear function. So see, it begs the question that is there an even better toxicity index function than the one we presented. So that's something that you can play with. There are probably infinite TI indexes that can be created that are still as good as the one that we proposed, and probably maybe even better in some situations. And that's something that is open. So in the last minutes, I'm going to talk a little bit about the paper that I haven't sent to you because it's still not published, but I will send to Vera the final draft. And it's a very interesting trial because it has to do with women that had breast cancer, and then they are going to be under treatment for 5 years to decrease the chances of having a recursion of the treatment. So, and those agents here, anastrozole and tamoxifen, they are very commonly used, and the problem here is that they have always some low-level problems like persistence of menopause symptoms or joint pains. And see, it's complicated for women that they want to have cancer again to undergo for 5 years of this treatment if they have this constant discomfort. So, and it's a very large trial. It starts with 3,000 patients, and we are going to talk only about the ones that the adverse event analysis. They had also the quality of life. This, remember, one of the things, the acronyms that we had was PRO, is patient-reported outcomes that were gathered also, but only in a kind of a third of the patients. And you can see that only 64% of women in this trial, they finish the 5 years of treatment. So this is adherence problem. This is a tolerability problem. And if you look at the comparison between the two treatments, anastrozole and tamoxifen, you can see that most of them had nothing. So you see that you have, it's a very different distribution than the other 6 treatments we've seen before. If you look at the sum of severe toxicity, 3, 4, and 5, are a little bit higher than 5% in both treatments. So most of patients have mild toxicity. And if you compare the toxicity index between those two treatments, see you have, again, there is a lot of people having close to grade 3 toxicity, but the shapes of the treatments are the same. Overall, there is no difference between them. Although you can find some specific classes of toxicity that are, for example, higher in tamoxifen. You can see that it's, the mean, tamoxifen has a slightly higher number of people with 3, even with anastrozole has some few patients with more than 3, but these profiles are not the same. Those Violin plots are not the same. However, the question here is not whether the toxicity between the treatments is different, but if we take each of those treatments separately, if we can find predictors of discontinuation. And what we done here, we used a well-known Cox regression model with time-dependent covariates, and we tested several variables. And guess what? Well, before the guess what, when we used the toxicity index, we could have a global TI, so we can take one patient and calculate all the toxicities together, or we can break them down per domain, see if it's endocrine, if it's digestive, if it's neurologic, or then go for the level. So this is the strategy that we did. So I'll give you just some preliminary data. If you do a univariate analysis and you compare within tamoxifen, see the overall TI, it's a predictor of discontinuation. So, and this was done per treatment. So tamoxifen was one model, anastrozole was a different model. But in both cases, the TI was the best predictor when you compare with all the others that we are not going to mention here. And this is, in this busy table, see, in the left side, you have the domains where that could predict discontinuation for tamoxifen and anastrozole. And in blue, you have similar domains for both drugs. For example, both tamoxifen and anastrozole had cardiovascular problems. In black are the ones that are unique for each treatment. So, and then when we go on the right side, we go from the domain level to the adverse event level. You can see that there is, see, in blue are the ones that were originally in the same domain, but then they start to be more specific. They don't match exactly. For example, you have in this one, blue still cardiac infarction, and here as well. And you have fatigue here and here as well. And then the other ones that were black have other subdivisions. And so, and why this is important? See, why it's important to understand what predicts discontinuation. Because what you can do, you can a priori identify what patients will have difficulty in tolerating a specific treatment. And this can help you find a better treatment that will be more tolerable to a patient. So just to, we have presently 8 projects that we are working. For example, Vinicius is working in this one. You can invite him to present his results. Marcio is working on new strategies for modeling toxicity. And also we have very cool, let's see if I can, no, I think that's too late. See, again, my presentation is already with Vera. If you can get it and go through those sites, and you can play with patient-facing material. So this is, we will be testing this with patients, because I have a good friend that she had breast cancer, she had a surgery, and she started to have a treatment for this endocrine type of preventive treatment. And she had horrible pain, and she couldn't take it anymore. And she asked me, André, can we, since you are studying this, is there any way you can do to help me to find what is the best treatment for me? So, and this gives us really the motivation to develop those applications where the patient selects what type of discomfort, in this case, she has, and you can see how likely is this to last for 2 years, 3 years or more. And this can say, well, maybe I will not have, I can't live with that type of pain, and I need to try a different treatment. So as a conclusion, we were very lucky that there was a funding mechanism that could be used to develop this research, and that's what we are doing. And hopefully we'll be able to help patients cope with their discomfort and find better treatments. So, and I'll be contente de receber questões para vocês, por vocês. Desculpe, o português ficou meio...
Alguém tem alguma pergunta?
Você viu que eu estou educadinha, né? O André, é muito legal a palestra, achei super, super interessante. E é algo assim que, desde que basicamente começou essa questão de, voltando aqui para a nossa pandemia, né, do mundo todo aí de coronavírus, essa palavra, como é? Adverso, como é efeito adverso, aí passou a ser...
Toxicidade, né?
passou a ser uma palavra assim bem usual no dia a dia da gente, né? Os pacientes que tiveram, até aqui no Brasil, houve uma guerra política, né? Porque o cara morreu por suicídio e associaram ao efeito adverso, mas relacionado à Covid, né? À vacina. Enfim, mas assim, eu vejo que é algo bem interessante. Agora, o que me deixou assim curiosa é a metodologia. Pela apresentação, você me mostrou o índice de toxicidade, né? É uma formulinha bem simples, né? É 1 menos qualquer coisa aí elevado, não é isso?
Isso, né?
E toda tudo que você obteve de resultado é baseado nessa formulinha.
Exato.
E quando você vai fazer a comparação entre o paciente ou tratamento, você usa um Cruz-Coalis,
Exato, é
teste
uma
Macaulay.
generalização do Cruz-Coalis, exato, que
Olha
permite, você tem ajuste de covariádos.
que interessante. Bom, isso assim, achei bem interessante porque assim, você não precisa saber muito de estatística para resolver o problema, né? É simples. Agora, por que você não usa inferência bayesiana? Porque,
Olha,
pelo que eu entendi, você tem informações a priori a respeito do paciente, né, antes dele se submeter ao tratamento, não é isso? Para saber se ele vai responder aquele tratamento, você tem informação antes, a priori, e você coloca isso aqui no
então não,
modelo, ou não?
você nem precisa tentar me convencer de ser bayesiano. Eu sou bayesiano, para
Eu
mim
sei,
a
por isso que eu
dor,
não queria entender por que eu não estou com uma metodologia bayesiana aqui.
a razão é a seguinte, o suporte desse Toxicity Index é maluco, tá?
É.
Ele é totalmente maluco, sabe? Ele tem buracos em todos os lugares, ou seja, não é trivial descrever um a priori para isso. E a gente tem um certo tempo, né, para fazer essa pesquisa. Então a gente foi pragmático e falou, bom, já tem metodologia frequentista, não paramétrica, que tem os pacotes em R que a gente pode usar hoje. Então, sabe, a gente começou nisso daí, né? Então, mas isso
Entendi.
não significa que você e todos os outros bayesianos agora pegam essas ideias, né? E fazer, vamos fazer do jeito bayesiano, né?
Eu
E
achei bem
o Márcio
interessante.
pretende fazer isso daí também, do jeito bayesiano, mas é uma coisa que, sabe, de novo, precisa sabe, esse conjunto aqui descreve a imagem, o suporte da distribuição do índice de toxicidade, né? Sabe?
Entendi.
Você pode ser que usando spike, priors, coisas assim, vai ser a solução, mas, sabe, não é trivial, não é que você fala assim, não, né, sabe, minha vida inteira, antes disso, eu estava trabalhando com beta binomiais, coisas assim, sabe, a gente tem um
Aham.
entendimento muito, muito bom disso, mas isso é diferente, é complicado.
Tenho certeza que o Márcio vai encontrar aí uma solução bayesiana tranquila, né,
Se ele
Márcio?
tiver tempo.
Uma outra pergunta, esse grau que é determinado já é uma coisa, não é determinado por você, já é uma coisa determinada na literatura, o grau de severidade aí de máximo,
Exato.
né? Já está tudo determinado. Então, você determina o que você tem de informação para o seu banco de dados é de acordo com esse grau de severidade aí
Exato.
da toxicidade.
Cada tratamento vai ter a gente chama um profile, né? Vai ter uma distribuição diferente e o tipo de toxicidade também. O Márcio tem um trabalho que ele nem usa esse índice de toxicidade, ele só pega esses graus de toxicidade e usando análise de correspondência mostra como que eles estão ligados entre si também. Então, sabe, tem
Não
muito,
basta.
é muito rico para fazer. Tem muita coisa que dá para ser feita. E uma coisa que ainda é mais, sabe, eu estou trabalhando com toxicidade, tratamento de câncer, tem um outro aspecto que o Vinícius está fazendo agora, o que o paciente reporta dele mesmo, dela mesma, mas se você pensa, o número na nossa vida da internet, né, o número de perguntas que a gente tem que não gosto, gosto um pouquinho, gosto mais ou menos, gosto bastante. Assim, a resposta categórica, ela sempre vai estar nesse tipo de distribuição. Então, todo esse trabalho aqui, você pode aplicar em psicologia, sabe, não é só câncer e toxicidade, né?
Entendi. Nossa, é bem interessante, sim. Mas eu vou deixar as perguntas para outras pessoas. Obrigada, André. Tá?
Imagina.
Alguém mais?
Tá baixinho o seu, Michel? E o meu alto?
Estão me ouvindo?
Estou ouvindo, mas aqui
Eu consigo te ouvir, sim.
Alguém mais quer fazer alguma pergunta? Não, mas...
Michel, tem uma pergunta. O André, achei o trabalho, assim como a Vera, achei bastante interessante também, parabéns. Eu fiquei numa dúvida, não sei se eu perdi alguma passagem, sobre a estimação do erro padrão do índice. A quantificação da incerteza.
Isso está no papel teórico. Eu pulei essa parte, eu só dei as coisas mais intuitivas. Então, vocês têm, eu mandei para a Vera open source o trabalho, né, porque foi suportado por você. Mas eu tenho só o desvio padrão quando você faz você vai pela poação, pelo limite de poações, né? Daí você consegue estabelecer o desvio padrão, a média, por isso que você consegue gerar o teste. Mas isso deixa eu ver se eu... Tá, isso está aqui na página 7. E a razão pela qual eu não entrei em muito detalhe nesse teste é porque esse teste é muito, sabe, é muito simples. É só para testar duas populações, né? Quer dizer, a gente não sabe como se você tem, como é que você ajusta por covariadas, tudo tem que ser feito. Então, por favor, vocês aí se tiverem tempo e interesse, manda ver que são todas coisas que são, sabe, vão ajudar a mover isso para ser mais usável do ponto de vista clássico bayesiano.
André, eu fiquei curioso quando você falou das priores, da dificuldade de se utilizar a abordagem bayesiana, porque por causa dos suportes, né, que variam. Uma coisa que é muito comum quando você tem priores pouco informativos, o suporte ainda assim não necessariamente respeita o suporte do parâmetro, certo? Então, talvez uma priori pouco informativa não contribuiria para isso? O que você acha?
Não. O problema é que você vai ter que... Quer dizer, não é um problema grave, é só complicado. Sabe? É que você... uma vez que você tem a fórmula analítica, que a gente acabou de ver, do suporte da distribuição. Então, quando você criar a sua priori, você vai definir, ela vai estar restrita nesse espaço aqui. Mas, sabe, isso daí automaticamente não te dá nenhuma ideia de qual distribuição, sabe? Acho que não deve ter. Será que tem alguma distribuição conjugada que você pode usar para isso daí? Provavelmente não, sabe? Vai ser tudo que você vai ter que fazer por deep sampling ou alguma coisa assim. Então, sabe, mas, de novo, você tem um tempo limitado e você tem que chegar a algumas, sabe, é triste que no final da carreira eu tenho que fazer trabalho que é não bayesiano, mas...
Faz parte, né?
Mas daí é para vocês que vão continuar e mostrar que tem maneiras mais eficientes e modelos que vão poder usar priores e você vai poder, né, update o modelo constantemente. Então.
Uma outra coisinha, pelo que eu entendi, então, pelo que eu vejo, você faz comparações com o max rate com a média, não é isso?
Exato.
E, aparentemente, a média ela tende a apresentar resultados não tão bons, né?
Então, um dos resultados que, por teorema, dá para mostrar que é powerless o teste, sabe? Ele tem problemas graves. Mas o que também é interessante nisso tudo, você fala, bom, então a média jamais deveria ser usada, mas o trabalho que o Vinícius está fazendo agora, quando você tem dados repetidos, né, no tempo, o método mais comum, frequentista, é fazer mixed model, né, modelos mistos que se usam. E eles são muito populares nessa área. E eles usam a média. Sabe? A gente não tem os resultados finais, daqui a pouco o Vinícius vai ter, mas parece que mesmo usando esses modelos, quando você tem toda essa estrutura de correlação que é mais complexa e você vai tentar fazer uma inferência, isso acaba não sendo tão prejudicial, né? Para mim, a priori eu achava, sabe? Eu acho que qualquer coisa que vai usar a média, por causa dessas qualidades que a gente está mostrando, do ponto de vista teórico, qualquer coisa ligada com a média deve ser pior do que usando esse índice de toxicidade, né? Mas eles são bem paralelos, porque a gente está fazendo nas simulações o não paramétrico com um modelo paramétrico, né? Ou seja, se a gente descobrir talvez uma forma paramétrica e bayesiana, ela vai ser mais eficiente do que o modelo misto.
Zero?
Eu fiquei curiosa de saber, quando você fala em longitudinal, significa dizer que você vai, para o mesmo indivíduo, você tem medidas repetidas?
Exato. Entende? Porque a situação mais comum, quando o paciente faz o segmento, ele reporta, desculpa, eu não sei em português como é que é isso, que é quando você tem patient reported outcomes, é um tipo de outcomes que são repetidos o paciente. Você pergunta, como é que você está se sentindo hoje em relação à dor aqui? Você fala, um pouco. Amanhã, mais. Outro dia, está bem pior, sabe? Então, isso é a estrutura básica desse tipo de dado. E é isso que a gente não tinha maneiras boas de analisar. Porque uma coisa que é legal desse índice de toxicidade é que você pode pegar, sabe, se eu esqueço a temporalidade, eu compacto todos os dados e analiso. Então, a gente já sabe fazer isso agora, né? A gente não sabe ainda como fazer com o tempo, sabe? São todas extensões que têm que ser feitas. Ou seja, tem muito campo aí para trazer coisa inovativa, né?
Interessante, dados de evento, que a gente chama de eventos recorrentes, né? Porque ele vai ter, o grau vai ser diferente, né? Pode ser o mesmo grau, o que ele recebeu, o que ele teve ontem, pode ser amanhã, né? Mas
Exato.
essas medidas podem levar a ter uma influência, ou seja, uma dependência também, né? Porque o grau, né, dele de ontem para hoje pode aumentar ou diminuir existe uma dependência. E Vinícius deve saber algumas metodologias aí, né, Vinícius, que pode resolver essa penega.
Vera, não, a gente está trabalhando com modelo misto, né? Como tem uma estrutura, né, ordinal, então a gente está fazendo um estudo para comparar essa abordagem que o André comentou, né, usando teste Gresham, né, que é o Probabilistic Index Model, com o modelo ordinal, usando o TI, a média e o máximo. A gente está caminhando aí para os resultados finais. Mas é bem interessante. É complexo, né? Porque o paciente não tem apenas um evento adverso, né? Ele pode ter vários e ao longo do tempo, né? Então vira uma estrutura bem complexa.
Ainda pode colocar a fragilidade aí, né, Vinícius? Porque deve ter fatores externos aí que pode estar influenciando bastante, né?
Que nem aqui no caso que a gente está trabalhando, né, Vera, aqui a gente não está lidando com, no caso específico, tempo até um desfecho, óbito, ou enfim, né? Aqui o que a gente está querendo investigar é o grau, né?
É o grau, tudo envolve esse grau de severidade aí, né? De efeito adverso.
É claro que isso, né, de alguma forma, acarreta no tempo até a ocorrência do desfecho, né, que é a continuação do tratamento. Né? Então, tem muita coisa para ser feita e, com certeza, dá para incluir fragilidade.
Ok, gente, muito obrigada aí Fiquei muito feliz, porque é algo que me brilha os olhos.
Tá ótimo, obrigado. Então, olha, vocês têm os artigos aí, vocês têm os contatos com o Vinícius, com o Márcio e comigo. Se vocês tiverem interesse, manda ver.
Maravilha. O Márcio não disse oi para a gente, né, Michel? Mas tudo bem, Márcio? Não sei se ele ainda está aí.
Talvez ele esteja com o microfone desligado. Mas, perfeito. Ó, está o Márcio. Mas, aproveitando que a Vera mencionou, antes de agradecer ao André, já abrimos um convite para o Márcio e para o Vinícius, para apresentar quando tiver os resultados um pouco mais prontos. Seria muito bacana se puderem retornar a casa, né, para uma apresentação.
Com certeza, viu?
O Márcio já tem.
Pode deixar.
O trabalho do Márcio já foi publicado, não tem mais desculpa agora.
Legal, Márcio. Ó, já está. Vamos compartilhar, né, Michel?
Com certeza.
Valeu, obrigada pela presença de vocês aqui, tá?
Obrigado a vocês.
Mais uma vez, muito obrigado, André, pela interessantíssima apresentação, que levanta, inclusive, não só interesse, mas nos ajuda a vislumbrar possibilidades de outras pesquisas, né, que são parcerias que possam render frutos interessantes.
Ótimo.
A ciência, né, gente? É a ciência.
Obrigado a vocês. Tá?
Muito obrigada mesmo, viu, André? Até a próxima. Márcio, Vinícius, obrigada aí por vocês estarem aqui com a gente. E vocês estão sempre convidados para participar dos nossos eventos a cada 15 dias, tá bom?